Hello, hi everyone. Today's session is about the atrial fibrillation. It is actually the continuation of our previous video on which we discussed about atrial fibrillation, its management, and how to deal with pre-op patients who are taking anticoagulation. This video is about the further management or detailed management about the atrial fibrillation and how to approach the atrial fibrillation patient stepwise. So let's begin with the management. We have already discussed the pathophysiology in our previous video. In this video, we'll be discussing the management. So let's suppose we have an atrial fibrillation patient. He has an ECG which has no discernible P waves. He has irregular rhythm, and we have just diagnosed atrial fibrillation. The next step is to determine is he hemodynamically stable or unstable. If he is hemodynamically unstable, we have to do electrical cardioversion, and that would be synchronized electrical cardioversion. If the patient is stable, then we have to determine, and we have to take the history that was that episode the first atrial fibrillation episode, or we can say that is that episode new onset atrial fibrillation. If it is the first episode of atrial fibrillation or new onset atrial fibrillation, then our approach would be to cardiovert the patient after obviously doing the echocardiography and watching if there is any thrombus inside the heart. Because if we cardiovert the patient and there is thrombus, that will increase the risk of stroke or acute mesenteric ischemia. So that is why it is very important to do the echocardiography. If the atrial fibrillation is old enough, more than 2 days ago, 48 hours ago, or it is not the new onset atrial fibrillation, then our next step would be to do the same thing that we did for the new onset atrial fibrillation. That would be echocardiography. Still, I'll repeat the same thing that cardiography is electrocardiography. Echocardiography is very important because we have to rule out the risk of thrombus and we have to see whether the cause is valvular or non-valvular cause. Valvular causes are basically, we can say, rheumatic heart disease or mitral stenosis that would cause thrombus in the atrial appendages because of the blood stasis. So valvular causes most likely have higher risk of forming the blood clots or thrombus. That is why we do echocardiography and we have to rule out the valvular cause too before doing the electrical cardioversion. So coming back straight to the point, we have to determine the thrombus. If there is any thrombus, then we cardiovert the patient. If there are any risk factors, uh, like the patient is uh, old enough, he has previous history of coronary artery disease, and he cannot be cardioverted, or if there is thrombus in the atrium, then what would we do? This is a kind of complex part. In this situation, when the patient is old enough, he has structural heart disease, he have coronary artery disease, previous history, then, or if there is thrombus, then we would go for the anticoagulation for like 3 weeks. And most common anticoagulation uses warfarin. If this causes a valvular cause, we would use warfarin. We are not going to use direct oral anticoagulants that are dabigatran, apixaban, rivaroxaban. We will only use the warfarin. We will anticoagulate the patient for 3 weeks, and then we will obviously do echo, and then we will cardiovert the. Even after cardioverting the patient, the atrial fibrillation is not settling, then we will go for the rate control and rhythm control medications, and we can use them until we uh, catheter ablate the patient, which is the most definitive or specific treatment for the atrial fibrillation. The last step toward treating the atrial fibrillation, which is catheter ablation, in which we catheterize the patient and we remove the abnormal aberrant foci in the atrium of the heart. So this is the basic framework for the atrial fibrillation. We have to see if it is new onset within 48 hours. We can cardiovert either electrically or pharmaceutically. Uh, Pharmaceutically, we can use antiarrhythmic 1A that are procainamide, flecainide. We can also use ibutylide, which is antiarrhythmic type 3. We can obviously do electrical cardioversion. If the patient is has having more than 48 hours since the atrial fibrillation, then we will determine the if there are any structural causes. Okay, if there are any structural causing causes that are not suitable for cardioversion, or there on which cardioversion would have no suitable impact, then we will go for rate control and rhythm control along with the anticoagulation. And then talking about the anticoagulation, there are two types of anticoagulation. If the cause is valvular, we will go straight to warfarin. There is no question asked. Go straight for warfarin. If there are no valvular causes, then go for direct oral anticoagulants that are 2A inhibitor, dabigatran or gatroban, and we can use also the 10A inhibitors that are apixaban and rivaroxaban. And then obviously we will also use the antiarrhythmics along with that. So this is the basic structural framework. Also, if your patient is using warfarin, in this situation, you have to counsel him or you have to look his medication history, because warfarin is metabolized by enzyme cytochrome P450 system, and those drugs that increase the activity that are inducers of cytochrome P450, these decrease the activity of warfarin or effectiveness for warfarin. Most likely, these are anti-epileptics like phenobarbital, carbamazepine, phenytoin, and I can remember a few more drugs like that are inhibitor. This is cimetidine is was CYP inhibitor. It is antiemetic. We can use metronidazole. It is also CYP inhibitor. And azoles that are antifungal, they are CYP inhibitors. Then there are drugs, azithromycin, macrolide. It is also CYP inhibitor. So inhibitor increase the activity of warfarin and inducers decrease the activity of or effectiveness of warfarin. There is St. John's wort, that is herbal medicine people use for depression. It also decreases the activity of warfarin. So you have to look for the medication history of patient. Do spinach, people eat the vegetable, that also induces the CYP enzyme system, so decreases the effectiveness of warfarin. So these are the things that you have to keep in mind when you are prescribing warfarin. You have to counsel the patient. You have to look for the medication history. So that's the basic framework we have already discussed. In the next coming sessions, we will be discussing other ACLS arrhythmias, ventricular fibrillation, tachycardia, atrial flutter, and their management. I hope this was helpful, and see you till next time.